Hello and welcome to today's live webinar on oral cancer brought to you by PortmanDentex. I'm Dr Asad Rahman, one of the clinician engagement leads, and I'm delighted that tonight I'll be joined by my colleague Dr Kevin Caruana, who is our lead clinician at the Smile Spa dental practice in Stockton-on-Tees near Durham. Oral cancer, as I'm sure you all know, is sadly one of the most common types of cancer in the UK, with over 10,000 new cases diagnosed yearly. Despite the high incidence, awareness of mouth cancer remains low, with a recent survey finding that 60% of the British public were unaware that mouth cancer could be detected during a routine checkup with your dentist. Our aim today is therefore to discuss this incredibly important topic. Throughout the session, Kevin and I will be answering your questions live, so feel free to pop them in the chat function below. And by the end, we hope that you'll leave with a greater understanding of mouth cancer and how early detection at the dentist could literally save your life. So I'll invite Kevin onto the screen to join me now.
Good evening, Asad. How are you?
Good, thanks. How are you, Kevin?
I'm good, thank you.
Busy day?
Yeah, always busy, to be honest. Don't really stop very much, but yeah.
Yeah, it never does it, in practice? No.
It's good. It's a good problem to have.
Exactly. So, Kevin, I suppose we'll start off just kind of discussing oral cancer in general and thinking as dentists, what are kind of the common ways we can educate patients about oral cancer?
Well, to me, it's very much, I like to keep things practical, basically. So it starts at the examination, right? You've got your medical history. And of course, on there, you've got how many units of alcohol the patient drinks, if they smoke and things like that. So I'm a bit like a broken record. So if I've told the patient once, I'm going to say it again and again and again until they stop. All right. So if somebody smokes, I'm going to explain why smoking is bad, apart from affecting gum disease. I'm going to explain that it increases your chance of getting mouth cancer. And I direct them always to the GP because they have smoking cessation clinics. And they're really good. I've had patients who work in them and they're really dedicated people. And they do work. They've got different ways of getting to it. So encouraging the patient to go there and stop smoking, apart from me repeating it. If somebody, of course, a lot of patients do have a bit of alcohol here and there. The moment, to me, it goes above 10 units a week. I know, I mean, for women, it's 14 units a week, 21 units a week for men. But to me, above 10, you increase your chances even more. So I try and explain, all right, keep it down, be careful. It does increase your chances of getting mouth cancer. And of course, if somebody smokes and drinks, I make it blatantly obvious that your risk is very, very highly increased. If you got children, I do actually, and the parent is there, have they had the HPV vaccine, which is arising as being one of the, almost on a level now, with smoking and drinking in chances of getting mouth cancer. And the vaccine is working. There's research out there. You can have a good look, and it is affecting, improving things and reducing the chances of mouth cancer from HPV vaccine, from HPV. If somebody's gone holiday, a bit of a spoil sport, I always advise them to put sunblock also on the lips, because it's another region which is usually not covered with sunblock. And of course, you've got the sun coming onto it. It's all about education. If the patient doesn't know and you haven't told them, well, they still don't know. So you have to tell them this. And I mean, of course, the Oral Health Foundation has got a very good website as well. I'm not sure if people are aware of this. Very nice summary, what things are about, very well organized. And there's also videos from patients who have had mouth cancer, and they're so good. Even if you direct the patients to them, sometimes if you're suspecting something or if they have mouth cancer, it's a good site to take reference from.
Yeah, that is a very good site. I mean, they provide lots of information in general oral health conditions, but specifically for mouth cancer, a great website, great resource there. Yeah. So when we as dentists are looking in a patient's mouth, are there any common areas that you're looking at where oral cancer arises more common than others?
Yeah, I mean, you've got high-risk areas. So, of course, you've got floor of the mouth, sides of the tongue, retromolar area, and the cheeks as well, really, white patches, which are not really going. Of course, you've got the linea alba, but those are the high-risk areas. So you always need to look for those. Having said that, I literally look everywhere. So let's say somebody comes for an examination. I start off with the mouth cancer check. So always look at the patient first, look on the outside. Are there any lesions which look suspicious? If you looked at things like basal cell carcinoma and things like that, like little spot which is a bit bumpy, I asked them if they had it checked by the doctor and things like that. So have a look from the outside. Then I start palpating. So I start literally below the chin, check lymph nodes. Are they enlarged? Keep going down. Then you've got the sternocleidomastoid. I make sure I go on the front surface of it, the back surface of it. I go behind the head. I've started pushing it more and more to go above the clavicle. I've seen some patients in the past who had big lumps here, and of course you don't want to miss them if possible. If something feels different, I'm starting to kind of ask questions to the patient. Oh, have you always had this? And if I suspect something, I mean, neck is not really our area as such, but I do advise the patient to go see the doctor and get it checked. That the mouth might be thyroid and things like that. One-sided lesion always raises more of an alarm. So I had a patient recently who had a big lump here on the right-hand side, and it felt like a balloon filled with water. A bit harder maybe, but that kind of consistency. I asked him to see the doctor about it. It turned out to be a lymphoma, an aggressive form. But because we caught it so early, they're very likely they're going to be able to treat it and basically save this person's life. Well, don't forget, I mean, they're married to people, they've got children. So it's quite a nice preventive check. So, of course, so check from the outside, check for any lumps and bumps. Then I get in my mirror, open wide, check roof of the mouth, cheeks, tongue, lift your tongue up, stick your tongue out as far out as possible and move it to the left and to the right. Now, when we're moving to the left and to the right, though, I put the mirror at the back to check the back side of the tongue. And if it's one of these patients who doesn't really put the tongue out as much, we always have a piece of gauze, so you can grab the tongue, tell them to relax the tongue, and you can literally maneuver the tongue and check better. Lift your tongue up so you can see underneath it. Now, some patients will do this thing where they don't really curl it backwards, and I just go, right, I need to see the floor underneath your tongue. And instantly it clicks and they give you a better view usually. Cheeks, of course, then I ask them to bite together and I still have a look further. At the same time, I'm looking for draining sinuses and things like that. But at the same time as checking, I'm talking to the nurse to type the notes. So the patient knows what I'm looking for. Even when you go down the neck, I'll tell them, I'm checking for mouth cancer. I would like to check, make sure everything's all right. Patients are completely understanding. And I'm seeing more and more patients who have had either a family member who have had mouth cancer, so more aware of it. They actually appreciate that you're checking. And so, that's how we tend to check.
I think it's, as you're mentioning, super important that you have a set protocol so that it's kind of consistent for every patient, as you've just mentioned, so you're not missing any areas. And a colleague of mine told me a funny story earlier because it just highlighted the importance of making sure that you tell the patient that you're doing this check, because they held a mouth cancer awareness open day. Obviously, as we all know, November was Mouth Cancer Awareness Month, and he had a patient attend that 2 days after their routine checkup, and it was because the patient believed that the routine checkup, even though the dentist had done the oral cancer check, they hadn't told them, they hadn't extremely kind of highlighted that they were doing mouth cancer checks. The patient thought, okay, they'll attend 2 days later for a separate mouth cancer check. So it's really important, as you're saying, to be telling the patient what you're doing.
It also adds value to your checkup. if they know what you're doing, they think, okay, this is what I'm coming here for. And when not the first time you say, okay, no signs of mouth cancer, and the patient says, okay, thank goodness for that. So they're engaging with you. If you just check in and not talking and passing the information on to the nurse, they just don't know what you're checking. To be honest, I even do it with decay, with gum disease. I'm just checking and talking to the nurse, and the patient is hearing what you're saying. So it's much more engaging.
Good. So yes, we're starting to have some questions through, which I'll read out the first off. So first question, have you ever discovered any signs of mouth cancer in your patients?
Yes.
And what was the process you took to kind of refer that patient?
Okay, so I mean, I've had patients where they've had, for example, an ulcer in the side of the tongue, and there was a sharp tooth next to this. So round off the tooth, check the patient again after 2 weeks. The ulcer is still there, although you could say it was a large ulcer. So it might not have healed after 2 weeks. So gave it another week or two, and it still wasn't healed. So we thought, okay, what's this about? So we referred to the hospital under the 2-week cancer rule. They took a biopsy. It turned out to be mouth cancer. So even though you think, oh, it's traumatic, don't always think that that's only the cause. It could just be coincidental as well. And this patient didn't even drink, didn't even smoke. But she was an older patient. Of course, the older you get, the chances of cancer is higher. As I mentioned, there was the patient with the bump in the neck, and that was completely coincidental. The patient is so grateful, honestly. You basically saved their lives. I had a patient with late cancer, and that was straight after COVID. They came in for an implant consultation because they thought they were going to lose a tooth. And as soon as you had a look, you had exposed bone, ulcerated gingiva, going all the way up to the lip as well. And this bumpiness on the palate. And I instantly knew there was something sinister there. I didn't even wait for the 2-week review after. I just referred straight away. If the suspicions are high, you just refer. And another one I had is a lip cancer, and that was treated early. It's healing beautifully, and the patient's very happy about that as well, because of course you caught it early, and it didn't spread. I mean, lip is quite an aesthetic area, is it? And of course you're seeing these patients after to review as well. But protocol. If you're suspecting something, explain to the patient. Review after 2 weeks. If after 2 weeks it's gone, perfect. Everybody's happy. If it's still not gone after 2 weeks, refer on the mouth cancer 2-week rule. If, of course, after 2 weeks it's getting better, but it's still there, I tend to get them back 2 weeks later. I want to see that lesion gone. If it's not going, I'm referring anyway. It's interesting. We were actually on our Christmas party last week, and this receptionist comes to me and she explains to me that a relative of hers has got mouth cancer, and apparently 3 years ago they biopsied it and it was nothing, and then 3 months ago they checked and there was this white lesion on the cheek. Referred again on the 2-week mouth cancer rule, and it turned out to be cancer. So even though it's been biopsied some time ago, it doesn't mean that it still might not turn into mouth cancer later.
And I think as you're mentioning there, it's never a bad idea to refer on the 2-week mouth cancer wait, because that's what the service is there for. They're never going to turn around to you and say, why did you refer this patient? So if there's any doubt, then why not send a patient? But I mean, I think as you mentioned,
there's a question from Afif Hadi.
Yes, I'll read it in a minute.
I'll just go through it. How severe would you say mouth cancer can be in comparison to other forms of cancer, and how swiftly is mouth cancer dealt with in the NHS? Now,
very swiftly,
as regards to severity, it depends how quickly you're diagnosing it. So the sooner you diagnose it, of course, the less severe it's going to be, especially with patients seeing dentists every 6 months to a year. You're more likely to catch it early, especially if you've educated this patient to look for white patches, red patches, and ulcers that don't heal within 2 weeks, to contact you straight away. So they know you're open to check this. They know you can diagnose, you're going to see them early, you're going to have your suspicions and refer under the 2-week cancer rule. And how swiftly, my experience of it has been amazing, to be honest. I mean, 2-week mouth cancer rule, but they're usually seen earlier than 2 weeks, and very, very swiftly. And you refer via email now with the NHS email. They confirm to you that they've received the referral, so you know that that's being dealt with. The patient's usually seen within a week, so I'm really, really happy with that, to be honest.
Exactly. Yeah, I think as clinicians, we know about the pathway, but what are some of your tips, I suppose, on handling that conversation when it's something where you are not 100% sure? Are you worrying the patient? We sometimes get nervous about that. Do you have any tips on that, Kevin?
So this is my typical words. So if I suspect something, I'll tell them, right, you've got a lesion here on your tongue, on the floor of your mouth. Now, I wouldn't lose any sleep on it. That's how I say it. I'll tell them, but I want to see that lesion is gone. You might have bitten it, rubbed it, but of course we want to make sure that if you have something like mouth cancer, we want to catch it early. So people do worry anyway. I'll be honest with you. They still think, oh gosh, the cancer is a possibility here. But I do strictly tell them, right, 95% of cases I refer. So I've checked them, I've referred them, come back as not being mouth cancer. So the risks as such, from what I'm seeing, are low, but we really need to check this. And they usually come in 2 weeks later, have a look, and if it's gone, perfect, we're happy. If the lesion is still there, I'll tell them, right, it's still persisting. I think it's better if I refer you on the 2-week mouth cancer rule. Don't worry, let's see you quickly. But it's best if they need to take a biopsy of it and confirm that it's nothing major. Having said that, the late cancer one I've seen before, that was a difficult discussion, I'll be honest with you. But you can't just say, I'm not going to say it, but it might be, because it might be a difficult conversation. I mean, you've got a patient in there. They need to know. You can't just leave it. It's horrible if you leave it, to be honest. So you need to get it across. I would reassure, especially if it's a lesion I'm not, it's kind of suspicious, but not exactly obvious. But of course, you need to make sure that they come back for the 2 weeks. You need to make sure that if you refer for the 2-week mouth cancer rule, that they are definitely going to go and get it checked.
And I suppose because, as you touched on there, the survival rates are so drastically different the earlier you catch mouth cancer, all cancers, but specifically mouth cancer, to the later stages. So so important that you have that.
To me, it's a pleasure seeing patients who have been referred for mouth cancer. They've had it treated. And you see them 5-10 years down the line, you're checking. I mean, some people with radiotherapy, so you've got certain limitations, of course, of wanting to preserve the teeth. You want to avoid extractions and things like that. But when you see that, you think to yourself, well, actually, this has been 10 years. This person has gained 10 years of further life of, so it's a massive thing. Catching early, though, is massive. So it's a constant reiteration. Stop smoking, reduce your drinking, use your sunblock. If you have any lesion, let me know, and reassuring them that you're happy to see them to check.
And you touched on some of the complications that can then happen after treatment, some of the dental complications. So what's your experience there been, having treated these patients who've come back after treatment? Obviously, the obvious one we all know is kind of salivary reduction, etc. What are some of your tips there on managing them day to day and then seeing them every 6 months?
I mean, of course, with dry mouth, you have to be careful that they don't start sipping on sugary things. So I make it very obvious, right? best thing, sip on plenty of water, carry a bottle with you. Salivary substitutes, they exist. I didn't get the best of feedback from patients about salivary substitutes, but I mention it in case they want to look into it. Of course, things like perfect oral hygiene, I'm very keen on that. So you want to maintain this tooth. They're usually quite well educated from the hospital side, I'll be honest with you. And they're aware that they have to reduce the need to take teeth out and things like that.
Yeah.
So, and of course, from our point of view, you don't want to have a cavity that you have missed. So you're really probing around. You're really going through all the corners to make sure that you haven't missed anything. You're taking your bite wings or your periapicals regularly. Any little sensitivity, you kind of think to yourself, I'm not going to leave that. I'm just going to investigate and trying to get to the bottom of it, so a proper diagnosis of why there is a problem. So that's key kind of thing. So yeah, dry mouth, radiotherapy, big one. Although with radiotherapy, you tend to liaise with the maxillofacial surgeons anyway. And they usually tell them, right, if there is a problem, you need to take a tooth out, contact us. Although I've had one patient where they told me, right, take the tooth out yourself. And if there is a problem, refer to us.
Yeah.
Just do it atraumatically as much as possible. And of course, it helps if you've done implants to know how to take a tooth out atraumatically. So, section teeth instead of just pulling, make it, elevate slowly. And,
yeah, not in my hands with my endo skills, but maybe in your hands.
Oh, is it?
Yeah, with your implant work, yeah.
You tend to preserve them, do you?
Yeah. I think, as you're touching on, and you see patients with facial reconstructions nowadays, and it's amazing what the hospital can do if sadly patients have had to have kind of extensive treatment during oral cancer. So they do kind of really reconstruct facial features, etc. So it's fascinating from that point. And then a lot of kind of restorative consultants do implant work in those really challenging cases, I suppose. Yeah. Another question that's come in, probably from someone younger in their career, saying that we always used to get told that you would see one case of mouth cancer in your whole career. Is that advice no longer valid? I think you already touched on that. You've seen, 3 or 4 in your career already.
Well, I think the more you read about it, the more aware you are of it, and the more you start looking.
Yeah.
I'll be honest, I think I've got at least once a month of a patient under review.
Okay.
So that's like 12 suspected cases a year, definitely.
Yeah.
I wouldn't say one mouth cancer case in their career, though, I'll be honest. Maybe one every 2 years, I would say.
Yeah.
And of course, you're maintaining some people who have had mouth cancer. So I think I know a good 15 cases that I've seen, to be honest. So
yeah. I suppose it varies in terms of populations you serve, areas you work in, etc. But like you're saying, it's sadly on the increase, isn't it?
Yeah, I mean, I'm not in a low-end practice or anything like that, so I don't have many heavy drinkers, heavy smokers, I'll be honest with you. It makes you wonder whether they're just more aware. I don't know, to be honest, but I've seen a good 15 cases in my career, so I wouldn't say one a year in a career. Maybe we're just more aware. Maybe we look for things more. But it's not just cancer as well. It's amazing when you start checking things. I mean, I mentioned before about thyroid and whatnot.
Yeah.
I mean, I've asked patients to have a look with the doctor, with their GPs, and guess what? Oh no, it wasn't anything cancer. It was thyroid. So suddenly they're on medication for thyroid, and they're very grateful that you've asked them to see the GP about it. So even skin lesions and whatnot, if it's a start of skin cancer, gosh, honestly, you can just remove it and you have a smaller scar. That's much nicer. But it's nice, you're seeing them regularly, and some people don't realize that spot is not a spot.
Yeah.
So
I think, as healthcare professionals, even amongst other healthcare professionals, we're in that unique position because we see them every 6 months, see people every 6 months. So really,
and of course, I mean, usually you're working with other colleagues who are maybe a bit older. Let's say you're quite young, you're starting off, you don't want to worry everybody.
Yeah.
I don't think colleagues mind if you kind of tell them, right, okay, can you just have a quick look? What do you think about this?
Yeah,
it's a nice way of working. You're learning as well. And it's give and take, because the beauty about the newer graduates is they're just fresh out of dental school. So the certain things that they're still fresh, and as you get older, you tend to forget. You talk and you see different viewpoints and how things are changing and mentalities. And it's give and take.
Exactly. Brilliant. Well, there's no other questions that have come in. So thank you once again, Kevin, for your time.
Pleasure.
And thank you, everyone, for watching. As Kevin signposted the Oral Health Foundation website, I'd really recommend that for us as dental professionals to look at as well. Lots of good information on there. And we hope to see you again at our next webinar. Thank you, Kevin.
Thank you. Thanks, Asad.
Have a good evening, everybody.
Good evening. Bye-bye.